TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
Well, welcome, Gail. I'm
Thank
so
you.
excited to be speaking with you. We've been chit-chatting before this interview started, and I can already tell it's going to be a fantastic conversation. So welcome to TNT Open Mind Insights. Thanks for coming.
Just thrilled to be here and so excited that you're doing this. So thanks for letting me be part of it.
Yeah, no problem. So first, I just want to find out who you are and what your motivations are for being curious, wanting to learn more and deepen your knowledge in addiction medicine.
hmm So I'm a family medicine physician by training. I started my career in the Navy, in the military, and took a little bit of a circuitous path. I've done a lot of different things, but most recently, probably for the last 15 years, I've been working with underserved populations in primary care. I worked for a free clinic where I was the medical director. We had about 70 volunteer physicians that were caring for patients. I went from there into the federally qualified health center system, and I was at one and then a second one. And it was actually, all these time I've been doing primary care, but I was very fortunate at my first FQHC to inherit a medication assisted therapy practice. I didn't
Mm,
know a lot about it. I hadn't had training in my residency. In the military, I wasn't exposed to it, but I had a physician that was doing it and he left the organization. And so I took over his practice. And I really learned it through on the job training, managing patients with substance use disorder, a lot of opioid use disorder. And what I discovered after, and I'd been in medicine for a while, even at that point, it was a surprise at that point in my career to find something that I really fell in love with. I've loved primary care, I loved women's health, I did all those different kinds of things, but there was something special about addiction medicine. And so I've just continued to pursue that
what do
path.
you think that specialness was?
I was thinking about that, and there's actually several things. One of them is, and this may surprise you, it's the medicine itself, and
Mm,
particularly buprenorphine. Buprenorphine is a very special medicine for those of us that prescribe. We prescribe lots of different medicines, but this is one that's very safe. It's incredibly effective. We have lots and lots of evidence to that effect. And if I give somebody buprenorphine today, by next week, they're feeling better and may not be using opioids.
wow.
And there's not that many things in medicine that have that rapid a response
Wow.
where you can really, really impact somebody's life and literally save them from dying
Wow.
with this medicine. So the medicine itself is pretty incredible. But that's maybe half the battle. The other half that I love is the relationship because I fully believe that helping people in recovery, all of medicine is about relationship, but particularly when you're treating people with substance use disorder, the system has treated them badly. Healthcare has treated them badly.
Yeah.
They've just had such negative experiences. And for me, it was a chance to really use that relationship building, trust building, learning a lot of things that we've learned here at the Train the Trainer, motivational interviewing to try to get to that person inside that's underneath that addiction and and kind of just try to bring that back out, try to help get the substances out of the way and then support them as people. So the relationships I've had with my patients in addiction medicine, it brings me to tears sometimes. I think about one of my favorite patients. I'm not caring for him now, but he'd spent 16 years in the federal prison system. Talk about somebody that had learned survival skills just to get through his life. He didn't trust anybody. And he didn't trust me in the beginning, this
Mm-hmm.
white hair, blonde, blue eyed
Mm-hmm.
person showing up in front of him. But over the course of a year and a half, we built such a strong relationship. And I cared deeply about him. He knew I cared deeply. Um, we cared deeply about each other. And I fully believe that that was part of his treatment, as much as the
Right.
medicine I was giving him.
They go hand in hand,
Mm.
don't they?
They really do, and that's why, people talk about pill mills, and that I just don't think that's the right model. The right model is about relationship, it's about meeting people where they are,
Hmm.
um, it's also about team. I've been very fortunate when I've done addiction medicine to always have a strong team around me, that strong nursing support. I'm a huge believer in peer recovery support. I've learned more from my peer recovery folks about treating addiction than I've learned anywhere else because they have lived experience. They help me understand, what it's like to go through that.
And what is
Behavioral.
a peer recovery group?
So these are folks that, again, have lived experience. So they're in recovery themselves. They had some type of addiction and they choose, and we see this oftentimes, they choose to give back.
Mhm.
They're so happy and so relieved to have gotten to be in recovery. They want to support their own recovery. I think that's one of the 12 steps is, reaching back and helping other people is part of supporting your own recovery. So I'm in the state of Tennessee, and I don't know, I can't speak for all the states, but there's a certification program that they can go through. And then they're really there. And I can tell you, there were many times I would be in with a patient and I could tell I just wasn't connecting with them. I wasn't understanding or they weren't understanding me. And it was just so wonderful to be able to go out and say, you know what? I think they really need to talk to you. And they
Uh-huh.
could go in and just really talk very much more straight up. And I've been there, done that, and help them out. So that's just a key part of the team. And then behavioral health. There's almost to a patient. There's either trauma or underlying behavioral health diagnoses. And I was, again, fortunate enough to be in an integrated care environment. So I had behavioral health right there. We could see patients side by side and really work to that really holistic approach.
Yeah. So
Yeah.
tell me a little bit about the struggles of the people that you served,
Hmm.
most recently.
Yeah, well, I think it goes without saying one of the biggest struggles right now is access. I mean,
Mm.
we could see as many as we could, but the need is endless, which is why one of my passions, I'm a primary care provider first that learned how to do MAT, and I love practicing and taking care of patients, but I'm equally as passionate about helping other primary care providers learn how to do this, honestly get over the fear of doing it,
Mhm.
address the stigma around doing it, and really because I believe that while we're starting to see some movement in the tide, overdoses have finally come down a little bit. There's still so much to be done. A couple of years ago on a lark, I looked up the number of people with opioid use disorder in the country and the number of primary care physicians in the country, and I did the math.
Mm.
And it's very unscientific. Please do not fact
Okay,
check
this is
this.
anecdotal
This is
research. Okay.
anecdotal in
Yeah.
on a back of an
Yeah.
envelope. But I came up with 30. And
30
so
what?
30 patients. So if
Per
every
primary care.
primary care
Oh.
provider in the country would take care of 30 patients that were ready for treatment. And that's obviously a whole nother ball of wax. But it just underscored for me that the more we can put this in the primary care sphere, we'll just never have enough treatment centers to take care of them. We'll never have enough addiction psychiatrists to do that. And we really need all of it. There's
Mhm.
some patients that need an addiction psychiatrist. There's some patients that need inpatient or they need a higher level of care. They need to be in a recovery center. But there's a lot of them that could be managed maybe when they come out of treatment by their primary care if they were comfortable with it.
Yeah.
And what's the best place to get that kind of care? And somebody that you have a trusted relationship with. Primary care is all about longitudinal relationships and continuity of
Mhm.
care.
Mhm.
And I think addiction treatment should be right there along with diabetes management and hypertension management and asthma management. And so that's something I'm really passionate about. And I actually think that's the hope for stigma because
Oh, interesting.
people won't, there's not as much stigma about going to your primary care provider. People don't know why you're going to your primary care. You could have, a stub toe, or you could
Yeah.
have, blood pressure issues, or you could be getting your MAT.
Yeah.
And so anyway, that's just a big area of passion for me. One of the main reasons I'm here in this fellowship is to be able to take what I've learned, learn more, and then hopefully be able to touch other primary care providers and get them comfortable with that idea.
Yeah. I actually went to my primary care doctor a couple days ago
Mhm.
just for a checkup and saw MAT a flyer on the wall.
Did they
I
prescribe it?
Yeah, they had like groups and there was a poster about
That's
it.
excellent.
And I was like,
Wow.
I'd never seen that
It's
before.
not very common. No, I've not
Okay.
seen it in my primary care offices, I don't think. Although the one I'm going to now, I think is going to start in that direction. So we're seeing more and more of it.
I love this idea that you can go in and you can get treated for it instead of
Yes.
like this is a personal failing is kind of like how I grew up. That was
Hmm.
the idea. If you're having these troubles, it's a personal
Hmm.
failure.
That's the stigma.
That's it. And you just got to buckle down and not be a failure, essentially, is the.
You know
But
what's
that's
so
it.
interesting to me, though? We never use those words when somebody has diabetes.
Mm-mm.
So much of diabetes can be really, there's genetics with addiction. There's lifestyle choices, there's lifestyle
You're right.
choices with
Yeah.
addiction. But we never talk about diabetes as a moral failing because,
Right.
you're a bad person and you got diabetes. We don't use that language. Addiction, substance use disorder is a chronic relapsing disease. Like diabetes is a chronic and can be a relapsing disease. And there's effective treatment for it. So and this is again, a big part of that, working in primary care, decreasing the stigma, taking it out of the shadows,
Yeah.
and because people with substance use disorder already feel so badly about themselves. There's so much shame. They
Yeah.
feel like they've failed so many people, and we just keep that going when that stigma continues.
Yeah. And so I notice, okay, so you've had um, experience already in addiction medicine before you came to this fellowship.
Hmm. I did, which
But
I was
what
thinking.
are you adding on more then? Are you learning more? Because I think,
I am. And I was thinking about this because I didn't kind of go that a fellowship and board to that route. I was very much on the job training. Like I said to you, I inherited a practice.
yeah. How long
Really,
ago was that when you first
it was in
started addiction?
2019.
Okay. Yeah.
So and so I think that's I'm a good person to think about this because I did it that way.
Yeah.
I was already
You just
practicing.
went for it.
I learned it. I had a mentor. I mean,
Oh,
he
great.
helped me. I worked
Yeah.
with him for a couple months and saw patients with him, but that very much that kind of mentoring apprenticeship on the job training. Because if you go to a primary care provider right now that's out busy and practicing, they're not going to stop what they're doing to go do a fellowship, and they're not going to be able to do those kinds of things. But I can say to them, you don't need to do that. The other thing is you don't have to bite off the whole thing all at once. Start taking care of a couple of patients that are already on buprenorphine and make that part of your practice, which is very much what I did. So I hope I bring that sense that this is doable.
Mm-hmm.
The fellowship it's reinforcing a lot of what I learned on the job. It's definitely adding depth,
Mm.
especially the focus on things like motivational interviewing and some of the approaches. There's just a lot of depth. It's a great building block for me onto what I know. And then what because it's all around train new trainers, that really drew me to it because I felt like this was set up so that I could take this and help other people.
That makes a lot
It
of
wasn't
sense. Yeah.
proprietary. There's not a sense at all of being proprietary, but
Yeah.
very much a sense of mission about wanting to make this practice more accessible.
Yeah. He the program wants you to spread
That's
this
right. That's
knowledge
right.
so you
So it
can
was a
do
perfect
that with
fit. It
them.
was a perfect fit. Yeah,
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 yeah.
yeah.
And so I want to find out a little bit more about just your personal views. Why do you care so much about, I mean, we talk a lot about caring for the patient, right? But you can't make someone care,
No.
right? And like maybe you might not care. Maybe you care more about something else. But why do you care about this individual that gets out of prison and comes to you? Like, where does that come from?
Wow. I think it's built into just being a primary care provider. And I think that's part of it. I guess I don't see practicing addiction medicine is so separate from practicing primary care. So it's the same reason you go into primary care. And you learn this over time. I can't tell you I knew this in medical school or even residency, but as you get more comfortable being in practice, and I had one of my physicians say to me, she was 5 years out. She said, I'm just getting to the point where it's the art of medicine.
Mm.
So that's the part where you're not as anxious about the didactic parts of it, but then you can start to explore that relationship part. And the beauty of primary care, when it's done well and done right, is, as I said, that continuity piece where you get to know. I mean, you talk to family practice docs out there, they're going to tell you they're happiest when they know you and they know who your kids are, and they might have taken care of your mom as well. And they know all those kinds of things because it's a relationship. It's just like any relationship. It's the depth is in that. So for me with addiction, I maybe it was because that relationship is so important and I put so much effort into it and built it so quickly. That's part of it. I am fortunate enough not to have suffered from a substance use disorder. Do I have it in my family? Of course. Who doesn't?
Mhm.
It's interesting. My mother was in, well, they didn't call it that back then. She was in addiction medicine. She was working in alcohol use treatment and
Mm.
actually had her own alcohol treatment center at one point. So I think that might be part of it. I don't ever think about that, but it's kind of been in my blood perhaps from the beginning. But I think this unique medicine, this relationship, and then the impact, as I mentioned. People that are struggling with substance use disorder have lost so much. And when you can help people not only get their life back, but get their kids back, get their housing back, get their job back, get their self-esteem back, it's maybe selfishly, it's kind of a dopamine hit. To be able
Yeah.
to touch people's lives and be able to help them in that way and serve them in that way. So maybe there's a little bit of almost there obviously is some personal impact for it for me.
There's nothing wrong with that.
Oh,
I
well,
mean,
that's
I
win-win, I think,
enjoyed it.
right?
Yeah, yeah, when you see your work making a positive difference.
Mhm. And it's hard. I don't want to paint too rosy a picture. I mean, you've done this long enough to know and I've never really looked at it, but there's many times where there's challenges. There's a relapse or the patients fall out of care and they don't come back. And I don't love that they weren't ready, but there's an element of where they are and the kind of support you can give them. So there's a lot of heartbreak. I mean, I've lost patients that I've been
Hmm.
taking care of to overdose.
Mhm.
So I think you have to kind of be ready for that too, um, and not. I don't see that as a. I think it's a failing of the system when that happens. I don't necessarily feel like I've personally failed because I know what
Yeah.
I've put into it. But and I think maybe for some people that's just not the right thing. But for me and for a lot of the people I know that do this work, I think that balance is okay.
Yeah.
Does that
So
make
how do you
sense?
take care of yourself to keep your spirits high and stay motivated?
Well, that's a great question. I can give you the list that I try to do. I try to do what try to practice what I preach. I try to make sure I exercise, eat healthy, try hard to get good sleep. Um, I'm really working on my the mindfulness,
Mm.
and I have faith and really trying to lean into that faith. So, because I know and believe that all of that body, mind, spirit we know that, right? They're intimately connected. I feel that though personally. So just doing all those kinds of things. Am I perfect at any of them? I am not.
Yeah, no,
We're
of course
all
not.
works in progress. I think I've heard you
Absolutely.
say that
Yeah.
before too, right? But I aspire to those things just to try to help live better and feel better. Um, I think for me, a lot of it I'm really trying to work on is balance. I do tend to go into things full force and
Mhm.
put a lot of energy into things, um, and sometimes that gets me a little overextended, whether that's physically or emotionally or relationship wise. So one of my challenges, and I'm working on, is just finding that balance, finding a little bit more inner peace, so that because I know if I'm there, then I don't want to bring myself into the exam room. I want to be
Yeah.
okay,
Yeah.
so I can be more of that, not a blank slate, but just more neutral. I want to
Yeah.
be the peace.
Yeah.
Like you're the peace here.
Thank
I
you.
wanted to be the peace in the
Yeah.
relationship and be able to be in that curious,
Yeah,
reflective
for sure.
kind of mode.
Yeah, I can relate to that. I feel that I can conduct better interviews when I'm not stressed out about
Mm-hmm.
something or having something really weighing me down. I like to see it as having clear eyes.
Mm-hmm.
When I look at somebody, I
Mm-hmm.
can see them really clearly and what they're bringing out instead of my stuff.
Mm-hmm.
My stuff is still important,
Mm-hmm.
but I'm dealing with it um, proactively in other areas
Right.
so that I can come fresh to the
It's a
table.
great model. I mean, it really, again, it's all about relationship. So our relationship here, or if I'm sitting in as the provider and with a patient, I want to do the same thing. I don't want to bring my stuff. That, as you said, it's important. But clear-eyed, that's a great. I'm going to keep that. That's a good metaphor.
Clear-eyed. Yes, and also I think it is hard to, meet people that are suffering, um, because if you're an empathetic person, you can kind of take that on.
It's a
Yeah.
challenge. That's one of we were actually talking about that in one of the sessions this morning. um, the balance between being there and being open for patients and having boundaries.
Mm.
And
Hmm.
that's a constant natural tension in the relationship because I am empathetic, but I also do have to maintain boundaries not only for myself but also for the patient.
Yeah.
It's transference. I think I am not a psychiatrist, but yeah, that it's safer and it's better, and that can be challenging when you're. I mean, I can feel it sometimes, and I've cried with patients, and I'm not sad about that. I think it's okay to be vulnerable and to show that, but I also have to be able to sit in that space where I don't bring my stuff to them. They don't need that.
Yeah.
um, does
Yeah.
that, yeah, make sense? Yeah.
That it is a really interesting balance to really care for that person, but not also bring into that place where it's harming you and then you can't be of
Right.
benefit anymore.
This is where the peer recovery support people shine.
Yeah.
So where I practiced my last time, would have huddles in the morning. And I was not alone in this. I had other providers, physician, nurse practitioner, and sometimes the peer support would sit in the huddle and they go, Dr. Reilly, you got to cut it. No, 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 no. You're
Cut what?
over functioning for
Over.
the patient. You're over
Wow.
functioning. You need to give them, they need to own this. They need to have this. And they would call us up on it, which was so healthy and
Yes.
so good because, especially, I don't have that background. So I really appreciated when they would just tell me, nope, I'm going in there. Nope, you need to just back
Isn't
up.
that
Isn't it? It was
interesting?
great. It was
Yeah.
great because we are, as they also said, that we are fixers in this profession,
Yeah.
and we have a lot of tools
Yeah.
at our disposal, and so we just want to get in there and fix,
Yeah.
but people have to own their own stuff,
Yeah.
and we each have to do 100% of our 50% as kind of a, I don't know if that works here.
Wow.
Yeah.
I had to think for a
Yeah.
minute. 100% of the
Uh-huh.
50%.
It's a
Okay. Yeah.
relationship. I
Yeah.
can't do your 50% and mine.
Yeah.
You have to do your work. I have to do my work, and we need to make sure that we're working together. But there's also that kind of that boundary.
Yeah.
But it's hard. It's
Hmm.
hard.
And I love the fact that you've brought up the peer support model and
Mm-hmm.
also like you're not alone in the work.
Mm,
And
mm-mm.
I think maybe others might feel that if they took it on, they would be alone and that could be scary. It's like,
I
no,
think
if
that.
you
Yep.
bring in a team, if you don't know the answers, then you can find someone who does.
I've been very fortunate, and you're 100% right. And any given day, sometimes we need to lean into the behavioral health person. Sometimes I'm leading into the nurse because she's got that best, relationship with the patient. And so it is that it takes a village. And I do think for some primary care that could be a challenge because they may not have that team. And I think this is where, well, a couple of things we need to do some work. A lot of that care is not reimbursed. And so I
Oh,
think from an insurance perspective, we need to
oh,
be
that's
think
hard.
it's very hard because it's hard to just give away care.
Mhm.
Things are expensive, healthcare is expensive. So I think we need to look at reimbursement models that are more comprehensive around that kind of thing, at least in the outpatient settings I have been in. I can't speak to all settings, but that's what we experienced. And then I think the other part of this, I was fortunate they were part of the organization I was in, but this is where community is so important. And while it's ideal to have it all integrated and in one place, I think you can build strong partnerships with community partners, whether
Yeah.
that's in behavioral health, even peer recovery support, other addiction organizations and nonprofits in the community. So I think people that want to get started, primary care providers that particularly that want to get started with this, can it may look different in different venues. I think you can still find that approximation and get that team-based care because it's a lot. It would be a lot in a primary care just to do it by yourself.
Yeah.
It, it would
Yeah, it
be,
would.
yeah.
And the other term I heard yesterday for the first time was cultural humility.
Oh,
Have you heard that
I
one?
have.
Yeah, and I noticed that's kind of what you were practicing with the peers and
Mm-hmm.
and being able to laugh at yourself and
Mm-hmm.
your overfunctioning and
Mm-hmm.
passing the torch
mm-hmm.
when it's warranted and
Mm-hmm.
working as a team. And what I was thinking about with this idea of cultural humility is you have to have a certain degree of, just inner confidence and self-esteem to be like, "Yep, I'm overfunctioning
Yeah.
and I'm okay with that and I'm still valuable and you're still valuable." That's the humility part,
Mm-hmm.
right?
Mm-hmm.
But also that confidence. So
Mm-hmm.
I just appreciate you coming and just sharing so openly and being such a bright, um, I don't know, representative of what going into this addiction medicine field can look like and feel like. And I just thank you for sharing your
Well, thank
wisdom.
you. It's easy. First of all, it's easy to talk to you, and it's also easy to talk about something that you feel so positive about, and and there's so much need, and where my passion lies in really working in this. So, thank you for that opportunity to talk about it.
Yeah. So if somebody wanted to learn more about the work you're doing, how would they reach you?
I think the best way right now is through the Tennessee Primary Care Association. I'm really fortunate that they've sponsored me coming to this fellowship, and they are a great point of contact, so I can make sure we get that link available.
Amazing. All right. Thank you.